Good afternoon, everyone. My today's talk is on approach to the posterior polar cataracts. What is posterior polar cataract? Is a dense white discoid plaque-like opacity situated on the central part of the posterior capsule. It consists of the concentric rings around the central opacity in the form of bull's eye, or we can say onion rings. The rate of intraoperative posterior capsular rupture and nucleus drop is high in the posterior polar cataract because of capsule around the plaque is often thin and weak. The plaque may be strongly adherent to the weak capsule, and there may be pre-existing posterior capsular defect. So, PPC management is a special challenge to the eye surgeon. The surgeon need to modify the technique to minimize the risk of PCR. Pre-operative counseling about the intraoperative complications should be well explained to the patient. That is the time taken for the surgery, the PCR, the nucleus drop, and the retinal intervention. It should be very clearly and honestly explained to the patient. A thorough pre-operative slit lamp examination must be done to find out the pre-existing PC defect, and posterior capsular integrity can be determined by ASOCT. So come to the surgical part. Do not overfill the anterior chamber with the viscoelastic, because if there is a pre-existing defect in the posterior capsule, injecting excessive viscoelastic into the chamber can cause posterior capsular rupture due to increased pressure into the anterior chamber. Now come to the capsular axis. The capsular axis should be perfect, 5 to 5.5 millimeter. In case of posterior capsular rupture, it will support the lens in the sulcus and optic capture can be done. It can be done with the rhexis forceps or cystotome. Then always avoid a large rhexis, because large rhexis, then if there is a rupture, then where to put the lens. And very small rhexis should always be avoided because it complicates the procedure. Some surgical modifications to be done. Anterior chamber should be stable. Use high viscoelastic, cohesive viscoelastic. Perform slow motion phaco and keep phaco parameters very low. Now come to the hydro procedure. Hydro dissection should never be done, and one should prefer the hydro delineation. In hydro procedures, what happens particularly in the hydro dissection? We inject the fluid in between the capsule and the nucleus. So there is a chances of nucleus block. I mean to say more hydraulic pressure is in between the already weak posterior capsule and the nucleus, and chances of PCR is more. And there is a capsular block syndrome as well, because when the fluid is injected in the capsular bag with an intact nucleus, it gets collected behind the nucleus and build up the hydraulic pressure within the bag, resulting in the PCR and nucleus drop. So hydrodelineation is the best procedure, but it separates the epinucleus from the endonucleus, and it creates a mechanical cushion of the epinucleus which prevents the PCR. Now conventional hydrodelineation is from outside in, and my preferred choice is inside out delineation. In conventional hydrodissection, what happens? The cannula penetrates the lenticular substance, then the fluid is injected, and which travels from outside to inside, like in this animation. Sometimes, particularly in the hard cataract, it may be difficult to introduce cannula within the firm nucleus, and there is possibility of unwarranted hydrodissection. Now what is inside out delineation? This is a very simple technique in which the fluid is injected from inside of the nucleus to the outside. The desired thickness of the epinucleus ball can be obtained because fluid can be injected with a cannula in the desired plane. Now come to the procedure. First, after rhexis, one trench is made into the center of the nucleus. Though the nucleus is very soft, so it is very easy to make a trench, but there should not be any rocking movement of the nucleus. Phaco should be done with the low aspiration, low vacuum, and low bottle height. This will provide a more stable anterior chamber with the reduced risk of the surge. This is the second video, again the same, and one can make the trench.
Gupta, you have only 2 minutes.
Yeah, I will finish, sir. No problem. The trench, then a trench is first sculpted, After initial sculpting, the fluid is injected through the right wall of the trench and then through the left wall of the trench. So the fluid goes from inside out and you are very safe. And we can customize the thickness of the epinucleus ball as well. If it is a hard nucleus, then there should not be any rotation of the nucleus, and nucleus is emulsified within the cushion of the epinucleus. AC well maintained during all the procedure. In hard cataract, chop in situ and the lateral separation
Thank you, Dr.
is my
Gupta.
choice.
We have 2 speakers on. The girl is showing 5 minutes more.
And in soft
very
cataract,
thankful to you.
a bowel is made, sir, 1 minute is more still. In soft cataract, a bowel is made to emulsify the demarcated nucleus. Epinucleus is also removed, separate epinucleus from the capsule by injecting viscoelastic, aspiration of the epinucleus with the low phaco parameters, and the central part of the epinucleus and plate should be aspirated in the last. You can put the IOL, and balls to be remembered, adequate size capsular axis, hydrodissection is contraindicated, inside out technique is a very safe technique. Avoid surge, nucleus is emulsified in the cushion of the epinucleus, and avoid polishing the posterior capsule. Thank you very much, and I finished 25 seconds.
Thank you very much.